Hello, hi good people. Today we are doing a video on the term known as preterm labor. So we are trying to do this topic, but at the same time we are trying to make it easier. So when you talk about preterm labor, we've two terms here, with the preterm and also labor. And from our previous videos, we've always defined labor as it's a process that do help us to deliver the products of conception, that is the fetus, the umbilical cord, the placenta plus the membranes. So now we are focusing on preterm labor. Just for some sort of an introduction, we'll say it's uterine contractions and cervical changes between weeks 20 to 37. So less than 37 weeks, then we're having uterine contractions plus cervical changes. At this point, we are terming it as preterm labor. So from what we're having just a diagram. Now this is the uterus. Yes, that's how the uterus looks like. Then with the fundus, which is here, I'll try point it out. These are ovaries. These are our fallopian tube, also known as the oviduct. We're just doing some small anatomy. Then we've now opening where we'll now get our cervix over there. So we've talked of preterm labor as labor or uterine contractions with cervical changes below 37 weeks. So if it starts between 20 to 37 weeks, that we can term it as preterm labor. So if we try check, so when labor kicks on, we'll always have the uterine contractions, which are tightening of the uterine muscle. So it tries to tighten, That's when we say it's contracting. At this point, if you try check the fundus, it becomes that hard like you can talk of your forehead. It's that hard. That means the uterus is really contracting. At the same time, while it's contracting, effacement is taking place, and we can define it as a pulling up of the cervix or thinning. So as contractions do increase, effacement takes place. At the same time, dilatation can just define it as it's something like opening. So the cervix pulls up, or the cervix thins. At the same time, it's trying to open up so as to release the products of conception. So at this point, we are confident to say that preterm labor is when we have uterine contraction and cervical changes below that 7 weeks of gestation. So now what can cause all this? What might bring about the uterine contraction with cervical changes before that 7 weeks of gestation? Ideally, we need it has to come after. So what can cause it not to come after and come before? So with various factors, we talk of uterine distension. Ideally, we are focusing on two people: multiple gestation and polyhydramnios. Polyhydramnios, we're talking about the fluid is too much. So this causes the uterus to be more distended, predisposing one to preterm labor. Two, multiple gestation. Multiple gestation, it means the mother has more than one baby in the womb. It also means the womb is that overstretched. Uterine distension, predisposing one to the topic that we are covering, which is preterm labor. Then another cause, we can talk of issues like stress. So for stress, when a mother becomes that much stress, the hypothalamic pituitary adrenal axis is always activated, and this releases the stress hormones. These stress hormones are the ones that will bring about labor, and labor might come in. Then another factor, you can talk of infections or inflammation. Then the fourth one is always placenta abruption, which you need to differentiate it from placenta previa. So you're just talking of placenta abruptia. So those are the four main causes of that might predispose one to preterm labor. Up to that point, I hope we are at par. So apart from the causes, we also have risk factors. It means things that might predispose you to getting preterm labor. So you also need to differentiate between the two. So what are the key risk factors? One, like for the slides, we've tried to put them into categories, and with those with the red, with smoking and substance use. So for smoking and substance use, it's always they are the two risk factors that will really cause this preterm labor. Then with other like preeclampsia and hypertension, placenta previa or placenta abruption. Infection is also a risk factor, and you need to remember we've talked it also under causes, then also placenta abruption. So placenta previa is also a risk factor of developing preterm labor. Then other risk factors like history of preterm labor, in case if the mother had other pregnancies where she experienced preterm labor or preterm birth, she'll always at risk of having another preterm birth or preterm labor. Then multifetal pregnancies, we've talked under the causes. Then premature dilatation of the cervix. It means the cervix starts to open up prematurely. So it will always trigger in labor to come in. Then we have uterine abnormalities. There are always also risk factors to developing preterm labor. What are the key signs and symptoms of preterm labor? So I've tried to classify them under uterine actions, then also cervical dilatation, because those are the two key things that we check. So most of them, they'll always present with uterine contractions. So we need to rule out, is this true labor or is this false labor? And how will you rule out? Ideally, we check for how regular it is, the activity, and also how is the pain. Is the pain radiating to the back, or is the pain fixed at one point? Then for cervical dilatation, we check the effacement and then how dilatation is progressing. Then they will always also have persistent lower back pain and also pelvic pressure, because at this point labor is coming in. Then if you try check vaginal discharge, there should be a change. So you try check if it's mucus, is it clear, or does it contain some sort of blood? It's always there. Then we need also to assess for premature rupture of membranes, which are mainly associated with preterm labor. So if all these signs and symptoms that you try check are persistent, and it becomes now a matter of concern, it's always key that you always contact a OBS-GYN. So at this point is the one who will tell us what to do next, because now we are, labor has already started, less than 37 weeks of gestation. This means there might be a lot of things. So we need to also take care so as to have better outcomes. So what are the possible interventions that we can do? So with the tests that we always do, one, we do the fetal fibrin, this one. So we do the vaginal swab, then we are trying to test the fluid that is coming out. Is it amniotic fluid? That's ideally what we do. Then we also do CBC. We want to do just to check for issues like with HB, probably when HB is low. And this will always help us, as also we do the type and the screening, so that we might have blood ready to help us. Then also need to do urinalysis, because UTIs might predispose one to preterm labor. Apart from that, UTI, it can be it can be confused with labor. So they will always be having a pain, but it's not radiating to the back. Probably there is some sort of urinary tract infection. So doing urinalysis will always help us to rule out. Apart from that, also urinalysis helps us to do more other things, because we always check also for glucose, we check for ketones and other things. Then we also need to monitor contractions. So if we are monitoring contractions, we want to rule out the aspect of true and false labor. Then we do digital cervical check. we are trying to check if the cervix is open or the cervix is closed. Apart from that, we're also trying to monitor how the dilatation is taking place. Then we also need to do an ultrasound that will help us more. So now we've confirmed this is preterm labor. So what is the patient-centered care? What are we supposed to do? So for we to have better, or let me talk of best outcome, you'll always meet this mother from week 20. Let me just talk of week 24 to around 32 there. So for we to have best outcome, there are things that we're supposed to do, because if we already have cervical dilatation, at this point we are thinking of more other things. Probably labor will kick in more well. Then we need to have prepared well. So we do corticosteroid, we do tocolytics, then we do magnesium sulfate, then we also need to do antibiotics. So let's talk about one after the other. So for corticosteroids, these are steroids, so they are surfactants, so they always help the lungs to mature. So if it's around week 28, we do the betamethasone or dexamethasone, depending with the protocol that you're having. There are protocols that reads of dexa. We do 12 mg OD for 3 days. Some read we do 6 mg BD for 3 days. Betamethasone same, so it depends with the protocol that you are using. So this always helps the lungs to fully mature, because less than 30 weeks the lungs are not yet well matured. Then we do tocolytics. Tocolytics are drugs that we give so as to reduce labor. We are trying to reduce the progress of labor, because at this point the baby is not well developed, then also the pregnancy is not yet at term. That's why we do tocolytics. So we mainly do nifedipine, we do terbutaline, are the ones that you're having there. So the essence of doing the tocolytics, we are just trying to suppress contractions, so as to buy more time for the mother and the fetus, so for the fetus to grow well. Then also we need to do magnesium sulfate. So magnesium sulfate, ideally we are trying to protect the neuro of the baby, and we are also decreasing the chances of developing cerebral palsy, which is always common in preterm labor if it's not well managed. Then we also need to do antibiotics, where we do ampicillin, gentamicin, so as to cover group B streptococcus. So in case our mother has too much bleeding, then if you try check the fetal well-being, like we're having non-reassuring fetal status, or the fetal heart rate is really dropping, then the mother had premature rupture of membranes. So at this point we don't do any other thing. We need to do the delivery immediately, because we are risking a lot. So maintaining the pregnancy and also doing the delivery will always outweigh maintaining, because of the increased bleeding, decreased fetal well-being, and also premature rupture of membranes. So just remember, for we to have better outcomes, we do the corticosteroids, we do tocolytics, then we do magnesium sulfate, not forgetting antibiotics, so as to cover the beta group B streptococcus bacteria. Up to that point, we are done with preterm labor. Just a recap, we've talked of preterm labor, and we've said it's when uterine contraction and cervical changes, they occur before that 7 weeks of gestation. Then we've tried check under the causes. We've talked of uterine distension, we've talked of issues with stress, we've talked of infection or inflammation, and placenta abruption. Apart from that, we've also looked at risk factors, of which we've classified them into 3 groups, where we're having the high risk, that is for smoking and substance abuse. Then we've preeclampsia, hypertension, placenta previa abruption, and also infections. Then others are history of preterm labor or preterm birth, multiple fetal pregnancy, premature dilatation of the cervix, then uterine abnormalities. Then we've done about the signs and symptoms. So where we check for uterine contraction, cervical dilatation, persistent lower back pain, pelvic pressure. Then we also do check the vaginal discharge. Then as we are doing all this, we also trying to rule out the aspect of premature rupture of membranes. So if all these are persistent and they are trying to be concerning, so you need to contact the one who is covering over there. So, and for the last part, we've looked at the tests that you're supposed to do. This mainly includes the interventions, and we've listed them, and also we've said how and why do we do this. Then finally, we've done about the patient-centered care. For we to have better outcomes, we do corticosteroids, we do tocolytics, then we do magnesium sulfate and some antibiotics. Then we've said we need to do immediate delivery if we're having too much bleeding, decrease fetal well-being, and also premature rupture membranes. Then lastly, these mothers were supposed to do activity restriction. Then also ensure that they are well rehydrated. Apart from that, we need to monitor fetal heart rate and also the contraction pattern. Up to that point, we are done with preterm labor. If there's any question, kindly you can ask. You can post down on the chat box, then we'll try answer. Thank you.